Hey guys, for another video, we're gonna talk about microstatic anemia in general. So let's get started with this case. As usual, I'm gonna pause it for a bit and just try to solve it yourself. It's fine if you get it wrong. We're gonna explain everything and get into differentials and actually solve it step by step. So 1 year old patient comes to the clinic, and patient was born full term. Whatever, you don't really care about that from internal medicine point of view. He eats meat and pasta and milk, and he does not eat fruit or vegetables. So, start off, he eats meat, which is something that is very rich in iron, and pasta as well, also rich in iron. Does not eat fruit or vegetables, and fruits and vegetables are highly rich in folate. And this is keeps in mind because if someone, for example, does not eat vegetables, fruits, drinks a lot of alcohols, you always think of macrocytic anemia, which is folate deficiency or vitamin B12. Regardless, conjunctiva and mucous membrane are pale, highly indication of low hemoglobin, not iron deficiency anemia, it's low hemoglobin. Can be anything causing anemia. There's no murmur, which is something that you should not really worry about, especially if the patient has conjunctiva that's pale and has, for example, a murmur of, let's say, ejection murmur, systolic. It's normal because most likely it's something called hypercirculation or hyper dynamic murmur. Basically, when the patient has anemia or low cardiac output, um, so the heart will actually eventually lead to more contraction and tachycardia, and that will lead to turbulence inside the heart and causing murmur. But regardless, this patient does not have it anyways. Abdomen is soft, no splenomegaly is noted. This is important. For example, in a patient has anemia and there's hepatosplenomegaly, you should always suspect leukemia or lymphoma or malignancy, because obviously the bone marrow will be overwhelmed, and the liver and spleen will take over, and probably do something called extramedullary hematomyopathy. Basically means producing RBCs from an origin other than the bone marrow. But this patient does not have it, so you kind of not gonna lean into malignancy. Let's go to the labs, which is the most important thing in the anemia approach. This patient has hemoglobin of 10, which is mildly anemic. He's not really severely anemic. RBCs is actually higher than usual because the maximum is 6 in this particular patient. It has 6.1. MCV, it's 60, severely low, by the way, and keep in mind it's severely low. RCDW, which is red cell distribution width, basically means how different sizes, like the variation between the sizes of the RBCs. So, for example, if someone has high RBCs or very big RBCs and small one at the same population, this patient has high RDW, but this patient has normal. So, all of them similar in size in this patient. Reticulocyte is 4%, and the normal is from half to 1.5. And reticulocyte tells you, the function of the bone marrow, if it's intact or not. Reticulocyte is basically the newly produced RBCs. This patient has high reticulocyte, basically means your bone marrow is effectively producing RBCs to kind of compensate for the anemia the patient has. So, we're gonna answer now. The answer is thalassemia, and let's just break it as a bit by a bit. We're gonna start with anemia of chronic disease. Basically, this patient, who has anemia of chronic disease, will come to you and has an autoimmune disease, or let's say an inflammatory disease that's been for like years, like rheumatoid arthritis, SLE. These patients have chronic inflammations that will lead to increase in complements, increase in ferritin, because it is an acute inflammatory reactant. All of those will cause the patients to hide their iron from the bacteria or from the inflammation, because you don't want to actually give iron or supplements for the bacteria or others. So basically the body kind of just gets all its iron to the ferritin and just hide it from the serum. So patients will have low hemoglobins, because obviously it's hiding the iron in ferritin. So ferritin is going to be high in anemia of chronic diseases. So the main pathology in anemia of chronic diseases is inflammations or infection. Folate deficiency, you probably might suspect in this patient because he doesn't eat fruits or vegetables, but at the same time this patient does not have macrocytic anemia because the MCV is low, so it obviously not answers neither A. Hereditary spherocytosis, it's actually a hemolytic disease. There is like a recurrent hemolysis, and these patients comes with a triad: jaundice, splenomegaly, and hemolytic anemia. So it doesn't have any of those actually. Iron deficiency and thalassemia is probably the only two valid answers you might pick in this situation because the MCV is low. So let's just draw a small diagram here. So anemia, it's basically hemoglobin is low. First step you do, you just look at the MCV, which is how big is your RBC. Now, if it's low, below 80, or normal 80 to 100, or higher than 100, for example, if it's below 80, it's microcytic anemia. This is normocytic anemia. This is macrocytic anemia. Now, in microcytic anemia, which is small RBCs, you should always think of two most important differential diagnoses. 90% of the questions is either this or this, which is iron deficiency anemia, or thalassemia, which is either a disease in the iron, which is basically low iron, or thalassemia, basically the globin part of the hemoglobin is abnormal. For macrocytic anemia, you should think of two things: either hemorrhage, the patient losing blood somewhere in the body, or hemolysis. Whereas in macrocytic, you should think of two things, which is B12 and folate. Obviously, the probably like 90% of the stuff, but there's obviously other things that actually come with microcytic or normocytic or macrocytic, but these things we should always think about when seeing, like, for example, macrocytic anemia. Okay, why did we choose thalassemia in that particular patient? Now, let's just explain briefly the pathophysiology of each disease. In iron deficiency anemia, you have low iron. So low iron, this is the RBC. It has, the heme part, the globulin, and there is iron on it. So let's just globulin and iron, which is obviously a part of the heme. This patient have low iron, but globulin is normal. This RBC will have low hemoglobin because obviously there's low iron. At the same time, this RBC will die sooner. It will shrink. It will shrink as it ages. So keep that in mind. For example, in thalassemia, it's actually different because in thalassemia, the iron is fine, but the globin itself is dysfunctioned. And when the globin is dysfunctioned, the cell will not live long. So it will live for a couple of days, but the end, it will hemolyze and reduce the iron. That's why these patients have high iron, just briefly. And obviously, can have anemia because the globin itself is the issue. Now, I want you to keep in mind there's a huge difference in between them. In iron deficiency anemia, the issue is with iron, which is dietary, which is fluctuating throughout the day. So if these patients, although they have very low iron, sometimes they will actually consume iron in their diet. So it's going to be like that, it's like iron is fluctuating. So in that manner, some RBCs will actually get enough iron to actually produce large RBCs, whereas other RBCs, for example, will not have iron in that day because it's fluctuating and they have low iron. So it will actually low. And these obviously going to shrink and become that. So there's different sizes inside the population. So the RDW will actually be higher, right? In thalassemia, the issue is genetic. So this patient will actually born with an RBC that has iron, which is enough, but the globulin itself is abnormal. So all of the RBCs, because it's genetic disease, will have the same size and the same condition, and they're all gonna hemolyze at the same time. So these patients will have normal RDW. Okay, so let's just get started with this table. It's basically comparison of iron deficiency anemia with thalassemia. Now MCV, as we mentioned, is going to be all low because the hemoglobin is low, and it's either an iron or a globulin. So both of them is going to be a low MCV. RDW, we just explained it, in R deficiency is going to be higher because there's, you know, different sizes inside the same population, whereas in thalassemia is going to be normal because they all have the same mutation and all the RBC is going to be produced from the beginning, same size. For the RBCs, in R deficiency anemia is going to be low. Why? Because there's a bone marrow, and the RBCs, as we mentioned, in R deficiency anemia, get to shrink and die sooner. Now, the bone marrow will compensate by producing reticulocyte, right? But this reticulocyte production will not happen because there is no iron in the first place. So there's no iron in the first place, so there is no compensatory. Also, there is a minimal reticulocyte production because, as we mentioned, the iron is fluctuating, but it's not gonna actually fully compensate for the hemolycyte RBCs that are gonna die sooner. So this patient will have low RBC because the reticulocyte will not be compensating at the same, not gonna be compensating faster enough. Whereas in thalassemia, it's gonna be normal or even higher. Why? Because the bone marrow is producing RBC, although it is abnormal because it has abnormal globulins, but the iron is there. So these patients will actually keep producing RBC no matter what. Obviously, they're gonna die sooner because, or hemolyze sooner because the globulin is dysfunctioned, but the bone marrow is healthy and will produce enough reticulocyte. That's why this patient, for example, had a reticulocyte higher, like 4%. In artificial anemia, you're not gonna see a higher reticulocyte. So these patients will have normal or even higher RBCs. In peripheral blood smears, we will have microcytosis and hypochromasia because hemoglobin is low. Whereas in thalassemia, we're going to see target sign, which is very pathognomonic for these type of patients. So you should memorize target sign for thalassemia. This both start with a T. This patient will come with anemia and low MCV. First step you should do is serum iron studies. This is the first step. What you're going to see? In RHS anemia, you're going to see low iron and low ferritin, obviously because the serum iron is low. The ferritin, which is the storage of iron, is going to be low. Now for TIBC, just imagine there is a transferritin, which is, by the way, it is a protein in your serum that holds iron. Now these patients, let's say for example, in transferritin, there's 4 seats, and there's not enough iron. So these seats are free. So there's increased TIBC. So TIBC is basically the space that can hold the iron. There's no iron, so the space will be higher. So TIBC is higher. In thalassemia, there is RBC turnover because these RBCs will die sooner and hemolyze sooner because the globulin is not gonna hold enough. So they're gonna die sooner and gonna release the iron inside of them. So the iron is gonna be higher. That's not gonna happen in the iron deficiency anemia because there is no iron to actually produce. And even if the cell dies sooner, the iron will not be significantly higher in your serum because it's literally a deficiency in the iron itself. Risk motor unstability, obviously in hemoglobin, will be higher in iron deficiency anemia, whereas in thalassemia is not gonna have any improvements because obviously it's not the issue. Iron is not the issue in thalassemia. For hemoglobin electrophoresis, it's basically you put the hemoglobin in your body and see like how fast they can migrate towards the negative charge. You should read it by yourself, but like basically it will show you what type of hemoglobins do you have in your body. In iron deficiency anemia is going to be normal, which is hemoglobin A if adult, obviously, and hemoglobin A2, these two like common in adults. In alpha thalassemia manner, which is alpha globulin chain. In alpha globulin chains, like all of them, which is hemoglobin A, A2, F, all of them have alpha. So if you have alpha thalassemia, all of these alpha will be low or absent. So all it's like proportionate low. So it's gonna be showing normal result here. Whereas in beta thalassemia, it's different because only hemoglobin A has the beta. So if there is no beta, hemoglobin A will be low or absent, and hemoglobin A2 will take over and will have higher A2. Whereas in F, obviously it's going to be, for example, first 6 months of life is going to be higher, and after that it will be very, very low. It might be increasingly a bit for compensatory of absent hemoglobin alpha. And that's it.